Good morning, everyone, and welcome to DeBakey Heart and Vascular Center Grand Rounds. Today we have a great topic and a great speaker combining two of my favorite things, adult congenital heart disease and transplant. And I'm thrilled to be joined with my good friend and colleague, Dr. Valeria Duarte. And this is kicking off our Adult Congenital Heart Disease Awareness Week. So for those of you who are watching, as per usual, we really would encourage you to participate. You can send in your questions either by text. If you text DeBakey to 37607, then you can text your message. Or join us by the web. Go to polev.com, enter DeBakey, and then just respond to the activity. So without further ado, I'd like to introduce our speaker. It's a good friend and a great colleague, Dr. Stephanie Fuller, who is a clinical professor of surgery at the Division of Surgery at the Children's Hospital of Philadelphia. She's the Thomas Spray Endowed Chair in Pediatric Cardiothoracic Surgery, and she runs the Adult Congenital Heart Disease program there and in Philadelphia. Stephanie is an internationally recognized leader in pediatric heart surgery as well as transplantation. She takes care of patients with congenital heart disease from the cradle into adulthood. And today she's going to speak about adult congenital heart disease and transplantation. So welcome, Stephanie. We're looking forward to hearing you.
Thank you so much. I really appreciate the invitation, and I'm happy to join you today.
Thank you. We are eager to learn from you.
Great.
So we're going to start the PowerPoint. Great.
Yes.
All right. There we go. Well, thank you once again, Dr. Duarte and Dr. MacGillivray, for this really kind invitation. It's a pleasure to join you. I'm a consultant for W.L. Gore. I'm going to go over a little bit of the epidemiology of adult congenital heart disease and hopefully explain how we're a little bit just at probably the peak of the iceberg here in terms of what this patient population has in store for us. I want to identify the patients who are at most risk for heart failure and explain some of the etiology of their heart failure. In addition, go into some of the details about why conventional therapy is not ideal for these patients. Lastly, I want to talk a little bit about kind of what our surgical approaches are for these patients, and as we continue to learn about both mechanical circulatory support as well as transplantation, and go through a little bit about our system here in Philadelphia in terms of how we manage these patients. Congenital heart surgery has certainly been an evolution, starting in the 1940s with the very early first procedures of closed heart surgery. And this was typically patients who underwent, for example, closed valvectomies or valvotomies. So typically these were procedures that were done either on inflow occlusion techniques or by forming a purse string in either the atrium or the patient's pulmonary artery, inserting a finger or device and to basically tear across a valve that was stenotic. The first procedure for congenital heart disease, obviously Walt Lillehei, University of Minnesota, in the late 1940s with repair of tetralogy of Fallot. And this was during an era in which cardiopulmonary bypass was first developed in the early 1950s. That was here in Philadelphia, actually at Thomas Jefferson Hospital. Open procedures really became more common in the late 1950s, including the advent of the atrial switch operation for patients with detransposition of the great arteries. That's going to be one of the procedures I go into a little bit more detail about today. We started doing more common open procedures in the 1960s and certainly stage procedures for more complex forms of heart disease. Neonatal or infant repairs were introduced in the 1970s, and throughout the 1980s and 90s, we continued to kind of improve our techniques and focus not so much on survival, but now also shift to what was the morbidity that we were accruing and how could we prevent that morbidity in patients. Over the last decade or so, we've really started to look at patients who have survived beyond childhood. So looking at adults with congenital heart disease and how we can extend the life of those patients, including assist devices and the concept of multi-organ transplant for these patients. kind of goes without saying here that these patients in general have continued to do well, but it's not limited to actually the surgical techniques. This is also a culmination of many other medical specialists, pharmaceutical advances, starting with prostaglandins in the 1980s, patients who had the introduction of cyclosporine to undergo transplants, and certainly a lot of improvements in terms of our imaging, our fetal diagnosis and treatment of these patients that got them to early intervention, advancements in anesthetics, and advancements in ICU management of these patients that really helped to prolong their survival. If we look at the epidemiology and the survival of the patients in the 1980s, it was predicted that we would have an increase of approximately 20,000 patients per year, about a 5% increase in the number of adult congenital heart disease patients. And currently it's estimated that we have between 1.4 and 1.5 million adults living with congenital heart disease. And just to put this in perspective for you, in about 2000, we had about 2.7 million patients living with atrial fibrillation, something that's a common everyday discussion, not only amongst physicians who manage these patients, but also that's a relatively common household term for anybody who has a parent or a grandfather who happens to be on anticoagulation for AFib. So you can imagine how common AFib is. It's estimated really by 2030 we'll have at least 1.5 million adults living with congenital heart disease. This is one of my favorite graphs out of Quebec, and this was done by Paul Carey. It's a little bit busy, so I'm going to walk you through. On the y-axis, we have the age of death for patients, and along the x-axis, we demonstrate the proportion of all deaths. The black dots represent the general population. So these are patients without congenital heart disease, whereas the yellow bars to the left and to the right represents patients who have congenital heart disease. And this is looking at two eras. So the years of 1987 to 1988 demonstrated on the left, and on the right-hand side, patients who then from 2004 to 2005. And you see two major shifts here. The first is that compared to the 1980s, patients in the year 2000 were surviving beyond infancy. So the long yellow bar at the bottom on the left-hand side indications patients who died less than 1 year of age is now significantly shortened on the right-hand side. These patients are surviving longer. Not only that, but if you look at basically how these dots are distributed relative to the yellow bars, you can see that essentially in the current era, patients with congenital heart disease much more similarly mimic patients in the general population, meaning they are dying now in their 70s, 80s, and hopefully their 90s, very similar to the general population. This effect was seen across all patients with congenital heart disease, but the greatest survival trend was really with those with the most severe forms of congenital heart disease. If you look at standardized mortality ratios in these patients, this is another very informative study looking at patients, and this is out of the UK, out of the Royal Brompton, another great area for adult congenital heart disease, as Valeria can tell you. Looking at patients with adult congenital heart disease and what was their standardized mortality ratio compared to patients who did not have congenital heart disease. You can see virtually every form of congenital heart disease tends to affect your survival when looking at age-matched patient cohorts. However, the most pronounced effect was once again for those patients who had the most severe forms of congenital heart disease. And I point out with the red arrows here, patients with systemic right ventricles and those patients with a Fontan circulation, in which you can see an exceedingly high mortality rate for those patients compared to patients in the general population. Now, this group went on and looked at patients in this is another way of looking at it, which is comparing basically the relative age for mortality that you would expect to see for patients with congenital heart disease compared to the general population. Again, age-matched cohorts within the UK's population. So if you look at systemic right ventricle, a patient who has a systemic right ventricle aged in their 20s, really represents somebody who has a risk of mortality, who is in their mid-40s or approaching 50s. The same is true for the Fontan, only now we take it up another decade. So if you're a 20-year-old with a Fontan, your risk of mortality is basically what it would be for a 60-year-old living without congenital heart disease. The real question becomes, as we move across across this table is how we get patients who are Fontans in their 30s and 40s to survive beyond their 30s and 40s. How do we treat them like normal patients in their 30s and 40s without congenital heart disease, as opposed to these patients who instead represent an age cohort of octogenarians? The risk for sudden cardiac death is really pronounced in patients with congenital heart disease. And this is a great study out of Barbara Mulder's group looking at the risk of sudden cardiac death. So this looked at 25,000 patients from longitudinal studies, 3 major longitudinal studies in the Scandinavian countries. And if you look at the risk of sudden cardiac death, you can see it's most pronounced for those patients with Eisenmenger syndrome, those patients with systemic right ventricles, and those patients with a Fontan circulation again. These tend to be patients, tetralogy of flow is also up there in number, but these are patients who tend to be at significant risk, the most severe forms of congenital heart disease. So when we discuss sudden cardiac death, it typically tends to be risk of arrhythmia as opposed to risk of heart failure. The lesions I want to go a little bit more in detail are those lesions of systemic right ventricle, meaning either detransposition, which has been palliated with an atrial switch. We really no longer perform this operation. In the 1980s, commonplace was doing a patient's arterial switch in which the coronary arteries were moved instead of forming a complex intracardiac baffle in the atria, which rendered the systemic ventricle still the right ventricle. Patients with congenitally corrected transposition who are unrepaired, those patients also have a systemic right ventricle. And lastly, the Fontan population. Hypoplastic left heart syndrome being patients who have a systemic right ventricle. So we can see that the right ventricle versus left ventricle have very different inherent functions. And this was a study published by my colleague here at University of Pennsylvania, Dr. Yuli Kim, looking at basically what are the differences structurally between the right and the left ventricle. We think of the right ventricle as basically a low pressure volume pump. It serves to transport blood to the pulmonary veins. As I describe it to my patients, it's basically the couch potato of the heart. It only has to send blood, but so far. It has a different developmental origin. Its shape is different, and its function is different, where it has a very low pressure volume loop and continues to eject during kind of a decline in pressure, as opposed to the left ventricle. The other thing that's important to note is basically the coronary supply is intrinsically different, with 2 coronary arteries supplying the left ventricle and only 1 to the right. And it's been proposed that this kind of circulatory imbalance to the heart muscle itself is one of the reasons for failure. If we look at risk factors for systemic failure, they tend to be a number of them. Increased afterload on the systemic right ventricle, as I described, coronary insufficiency, the presence of tricuspid regurgitation, and many of these patients who have been palliated who tend to have residual lesions and sequelae of their surgery, and lastly, the presence of abnormal heart rhythms. And I think these arrows could generally point in either direction. This tends to be very much a vicious cycle in the scheme of heart failure. When we look at the 3 populations that I identified earlier, the atrial switch, congenitally corrected transposition, and the Fontan patients, you can see that for all these patients, we tend to have a similar 20-year survival, which is about 70%. Of note, if you look at patients with congenitally corrected transposition, there is a significant discrepancy in these patients in terms of whether they have tricuspid regurgitation or not. Those patients who do not have tricuspid regurgitation have a much better survival and improved ventricular function compared to those that do have tricuspid regurgitation. If you look at the Fontan population in general, the Fontan survival tends to be quite different based on whether you have a right ventricle or a left systemic ventricle. And these are 2 studies, looking at Fontan patients, the one on the left from University of Michigan, and the one on the right from Children's Hospital of Philadelphia. Both of these demonstrate a significant difference in survival for patients with a Fontan based on whether they have a right or a left ventricle. Usually it's about a 10 to 20% difference in these cases, with about a 78% survival at 25 years in patients who have a systemic left ventricle compared to 63% in those patients who have a right ventricle out of Michigan study. And that was statistically significant in their series. That was published in 2020 with Ming Singh as the lead author. So what exacerbates heart failure in these patients? Well, typically in patients with a systemic right ventricle, the two things I mentioned tend to be tricuspid valve insufficiency and the presence of arrhythmia. So in patients who have had an atrial switch operation, this is a Senning and a Mustard operation, two very similar operations when using a synthetic baffle, for example, bovine pericardium, as opposed to really kind of wrapping or enveloping the patient's native atrial wall to form this baffle that redirects blood flow. So while the ventricles aren't moved, the right ventricle still provides blood flow to the aorta. It is receiving oxygenated blood through its tricuspid valve from the pulmonary veins. And in the case of the left ventricle, which is providing flow to the pulmonary artery, this is now cyanotic blood from the systemic circulation that's traveling through an interatrial baffle over towards the left ventricle. These patients tend to suffer from arrhythmias that can be bradyarrhythmias, mainly sinus node dysfunction. They can be tachyarrhythmias, for example, intraatrial tachycardia, and they can contribute to sudden cardiac death. Ventricular arrhythmias tend to be much less common in this group. They can also suffer from either baffle leaks or obstruction. These are most commonly seen in the systemic baffle at the superior or inferior vena cava and often are treated with stents. These can be commonly seen as a result also of pacemakers. These patients have arrhythmias. Oftentimes they're treated with their bradyarrhythmias with transvenous pacers, but these can often lead to baffle obstruction in the superior limb. These patients also tend, as I mentioned, to have tricuspid valve regurgitation and systemic right ventricular dysfunction with a very complex relationship between the two of those. So how are these patients medically managed? Well, of course, we try to extrapolate from the general adult population. So when we look at trials of these patients, if you look at the number with the N for all these trials that are mentioned here, it's really a small number of patients who are treated. And what we would anticipate tends to be the treatment for patients who would have large multi-center studies. So we're not looking at 20,000 patients who undergo treatment with beta blockers. Instead, we're looking at 8 patients, for example, in the middle. And you can see that for some of these, the treatment really is inconclusive. Are we really helping these patients? In many cases, when you look at their New York functional class, the results are fairly equivocal. We don't know that we're actually reducing the dimension of the right ventricle, whether we're improving exercise capacity or whether we're improving the functional class for patients. This is what we have to offer, and we simply put these patients on these medications, hoping that we'll have some degree of improvement, but I think there's a tremendous amount of variability in terms of how these patients are treated medically. When we look at tricuspid regurgitation, this is probably the most famous study that's been looked at and examined. And this is, again, a study from Columbia, looking at 40 patients that were followed over a cohort of close to 20 years, 17 patients with significant tricuspid valve dysfunction and 23 patients without. And what we see is a real increase or predisposition to RV dysfunction in those patients with tricuspid valve regurgitation, to the point where severe TR was significantly associated with RV dysfunction. This really proved to us the relationship of both tricuspid valve regurgitation and RV dysfunction in this population. But the other thing this study did was point out that the mean time from the onset of tricuspid valve regurgitation to development of right ventricular heart failure was only 5 years. So these patients are clearly on a pathway to heart failure. It's very hard to know kind of how to manage these patients and what's the best trigger point for doing a valve replacement. As I'm sure Dr. MacGillivray can tell you, oftentimes these patients will present once they already have significantly depressed right ventricular function, and they're not going to tolerate any type of intervention on their valve. But this, again, being a very important study for us out of Columbia that looked at these patients. Again, out of the University, Mayo Clinic, the study looking at tricuspid valve replacement for these patients and transplant-free survival after systemic AV valve regurgitation. And you can see that those patients with a cutoff, this was an aberrant cutoff of 40% that they looked at, there was a significant difference in survival for those patients who underwent a systemic valve replacement when they had an EF greater than 40% compared to less than 40%. And this was a predictor of survival 1 year after systemic AV valve replacement in these patients. So really, these are patients who, if we can intervene surgically with a systemic valve replacement, we need to capture these patients fairly early in their heart failure course. And really, the recommendation from Mayo Clinic was to replace the systemic ventricle before the RV fails. Again, this was a relatively small study. This was 46 patients, but this is what we based basically our surgical intervention on, 46 patients in this population. The last thing I'll mention in terms of regurgitation for these patients is cardiac resynchronization therapy. And this is certainly a point of controversy for patients with a systemic right ventricle. And one of the reasons it's controversial is because there tends to be a wide variety of recommendations. If you look at the European guidelines for resynchronization therapy in these patients with heart failure, really, they don't even mention it. CRT is considered to be experimental in these patients. If you look at the most recent AHA-ACC recommendations, they don't even mention resynchronization therapy for these patients. But if you look at the PACES Heart Rhythm Society recommendation, it does state on a level 2A or level C recommendation that CRT can be useful for adults with systemic right ventricular function of less than or equal to 35% in sinus rhythm with a complete right bundle branch and with a QRS complex of greater than 150 milliseconds. And these patients typically benefit if they're in a New York Heart Association class 2 or 3. What becomes challenging about these patients and in terms of the resynchronization therapy is oftentimes these patients do require a repeat sternotomy for any type of pacemaker intervention, especially in those patients with a single ventricle circulation. So keep in mind that for resynchronization therapy in these patients, it can be a challenging therapy for them in terms of how we're going to get them resynchronized. And for these patients, particularly those that are prone to baffle leaks or may already have a pacemaker in place, what's the best surgical approach versus an interventional approach for these patients? In terms of what makes the Fontan different or unique from those patients with a systemic right ventricle, it's really quite challenging. Not only can they experience pump failure, they can also experience what we call Fontan failure, which is patients with a very normal systemic ventricular function who are failing and present with end organ dysfunction. In addition, this tends to be kind of a double whammy for these patients in the sense that they are cyanotic. We first started learning about kind of failing Fontan circulation from Barbara Deal and Marshall Jacobs, who published this great report, Barbara Deal being at the Mayo Clinic, working with doctors Mavridis and Backer, looking very closely at patients with Fontan failure. And this was originally kind of an approach to take patients who had an old style atrial pulmonary Fontan and convert them to what was an extracardiac Fontan, and in the process, treat their arrhythmias with a MACE procedure. These patients experience a lot of kind of variability in terms of their failing Fontan. So not all of these are manifest in every patient, but patients very selectively tend to pick, choose, and potentially exhibit all of these. Of note, please note that these patients can have atrioventricular dysfunction. These patients can have ventricular dysfunction, as I mentioned. They can be patients who are very prone to having increased coagulopathy or increased prone to coagulation itself and forming clot. They tend to be patients who are very arrhythmogenic. They can have intracardiac shunts or veno-venous collaterals and AVMs that make them cyanotic. They can also have pleural effusions. They can have ascites, and they often have metabolic markers that indicate just their level of dysfunction. The liver and the Fontan circulation is one of the biggest trouble points for us. And realistically, it's very hard to kind of understand why these patients tend to have most significant liver dysfunction. And Dr. Duarte can certainly probably tell you a lot more about this in better detail than I can. But we understand that these patients tend to develop increased CVP. And so these patients tend, as passive flow into their liver, tend to get increased pulmonary vascular resistance, tend to get increased congestion in their liver. And as a result, they can have decreased cardiac output. Over time, this can decrease the return that they have from their portal vein and increase the flow to their liver through their hepatic artery. And their hepatic buffering system really tends to struggle with this kind of effect. The increased hepatic artery flow is in response to decreased portal vein flow and portal hypertension in these patients, all of which leads to potential liver dysfunction in these patients. And over time, these patients tend to develop the many side effects you see here, as I mentioned earlier. Specifically in their lungs, they can have decreased functional capacity. That can also be related to serial operations. And oftentimes in these patients, it's very quick to point out, I'm very quick to point out, when we're evaluating these patients for transplant, for example, it's very easy to see on these CAT scans. It's not unusual that these patients will have one or both elevated hemidiaphragms, which means that they have decreased functional capacity simply by the nature of having previous phrenic nerve injury. They can have plastic bronchitis, and that's an indication for transplant that we see in our pediatric population, and pulmonary vascular remodeling or patients with elevated pulmonary hypertension. These patients have a higher incidence of stroke, in part due to their cyanosis. They can have a loss of complex brain function, and we see that even in the pediatric patients. The liver, we mentioned already, their kind of predisposition towards fibrosis and cirrhosis in the liver. Renal dysfunction in terms of reduced GFR in these patients, PLE and gut edema, mainly attributable to these patients having a high CVP. We can see decreased skeletal mass in these patients. Usually if they tend to have less exercise tolerance, they will have less muscle mass and lower bone density in these patients. This goes along with endocrine dysfunction for these patients as well. They can have lymphopenia and hypogammaglobulinemia, which is often seen in the Fontan patients, and of course the lymphatic abnormalities, which we continue to learn more and more about. We've abandoned liver biopsy here at University of Pennsylvania for our patients with Fontan and end-stage liver disease. And this is based on the fact that many of these patients exhibit cirrhotic-like properties, even if they have significant fibrosis as opposed to cirrhosis. So usually the elevated CVP can contribute to dilation of the sinusoids. Decreased perfusion can attribute to the centronobular necrosis we get in these patients, and all these patients tend to develop some degree of either fibrosis or cirrhosis. The laboratory tests are not helpful in these patients. Usually they have oftentimes very preserved synthetic function, and their cholestatic pattern tends to be quite normal. They can have hypoalbuminemia, which may be related to either PLE or plastic bronchitis in these patients, and they can have a PT elevation, but it's confounded by Coumadin. Many of these patients are maintained on Coumadin just for their prothrombotic states. So oftentimes when we look at their livers, we looked at a MELD score for them that doesn't include obviously their PT, and other factors can be awry in these patients. We don't use fibrotic markers clinically. They don't tend to be helpful in these patients. And instead we do a lot of imaging and tumor markers to assess for cirrhosis, hepatic nodules, and even the development of hepatocellular carcinoma. We typically have 1 or 2 patients a year who are listed for transplant because of the presence of hepatocellular carcinoma. To date, we have 1 adult Fontan patient who actually is a high-performing Fontan patient, currently a 4th-year medical student who in the last couple of years has run a half marathon. She's our only patient who actually underwent resection of a hepatocellular carcinoma while a Fontan, simply because she did have otherwise a well-appearing liver and no cardiopulmonary symptoms, and she did very well with that. So again, the clinical complications of cirrhosis in these patients or hepatocellular carcinoma that really lead us to potentially needing to perform a liver transplant in these patients or in conjunction with a heart transplant. So we're extrapolating both now from our hepatology world in addition to cardiology. And we continue to learn more and more about Fontan-associated liver disease. These 2 publications, one from 2017 and one from 2020, which are helping to better inform us. Fontan patients tend to develop cyanosis as well. This is, as I mentioned, because of veno-venous collaterals, the presence of fenestrations, baffle leaks from patients who have an extracardiac or even a intracardiac Fontan, and patients who can form pulmonary AVMs. These tend to be significant in these patients. If these patients don't have any, for example, fenestration, and they continue to have saturations that are low, we really look for sources of that cyanosis, as it's not normal. Oftentimes in our conference, we'll get a patient sent to us for evaluation for transplant. And once we learn that the patient's not fenestrated, but they're significantly cyanotic, we like to point out, hey, that's not normal, and we need to look out for something different. Collaterals tend to be fairly varied in these patients. They can be aortopulmonary collaterals, in which patients have oxygenated blood from the systemic circulation that go to the lungs. So these tend to be left to right shunts. They can have cyanotic congenital heart disease, for example, patients who have TET, MAPGUS, any type of aortopulmonary collaterals commonly seen with pulmonary atresia or the single ventricle patients. And then the presence of bronchial arteries, all of which can contribute also to elevated pressure in the lungs, increased pulmonary venous return, which cause a volume load, increased PA pressures, and potentially hemoptysis for these patients, which can be life-threatening. When we look at the veno-venous collateral, this is what we tend to see also in patients who are Fontan patients. And these can be veno-venous collaterals that form a right to left shunt. So essentially recanalization of obliterated embryonic vessels, pop-off decompressions. These can come from the systemic circulation, IVC, hepatic veins, SVC, azygos, subclavian veins, and connect to the pulmonary veins or to the pulmonary atrium or even to the coronary sinus. And these tend to represent sicker Fontans for us. These are really patients that tend to be quite a problem when it comes time for transplant. And we have very little data on this. Probably the best data we have is out of UCLA, where Jamil Bolson, one of the interventional cardiologists there, has been particularly aggressive with these patients. And when they're listed for transplant, Jamil has been bringing these patients in usually about every 6 weeks for a planned embolization therapy once they're listed for transplant. So you can imagine just kind of the overwhelming burden on these patients of having procedures done every 6 weeks, but then also, an attempt to kind of minimize the amount of bleeding at the time of transplant for these patients. So it's really quite fascinating. In terms of pulmonary AVMs, this is something that's really important for us to point out to our colleagues in transplant medicine. The most recent patient, Fontan, who we transplanted, who had significant AVMs, not only in her lungs, but also systemic AVMs, so in the knee joint, in the palm, for example. And these patients who tend to have a significant amount of shunting even after their transplant. So it's always concerning to the cardiologist when we finish a heart transplant, and now that newly transplanted heart is living in a milieu of a systemic saturation of maybe 80%. 85%, which is something that is very untoward, obviously, when you have a patient who had a transplant done already. And we have to make a decision about how aggressively we're going to treat these, knowing that many of these will regress once the patient is actually well oxygenated. So these are typically detectable by contrast CT. They can be in areas where there's a lack of hepatic effluent. For example, if there's an uneven kind of flow between the pulmonary arteries, where the majority of the Fontan flow through the baffle or the inferior vena cava is going predominantly to one lung versus the other. So this can certainly be a burden for our patients after transplant itself. I have a couple images here to show you of kind of the patients who we're a little bit wary of, and what we're doing at the current point is going through with our radiologists and really trying to classify patients who have systemic AVMs. And this is a CT scan of a patient listed for transplant. And as we scroll through this, you'll see emerging, obviously, with bright here being the contrast material in the arterial phase. And as we get up into the chest, you can see that there tends to be a significant amount of arterial collaterals, which I'll stop and point these out to you, already accumulating kind of in the posterior mediastinum, but then also starting to develop and work their way around the bronchioles themselves, anterior to the patient's pulmonary arteries on both sides. And these are the patients who we get very worried about. You can see here around the SVC surrounding the trachea and peri-aortic. These are the patients who tend to have a lot of significant bleeding complications at the time of surgery, who we're particularly worried about. Here's the left SVC that's also surrounded by collaterals. These are the patients we tend to worry about when it comes time for transplantation and what their bleeding risk is from this. This is another specific example of a patient who tends to have significant collateral burden, and in this case also has a stent over in the left pulmonary artery. And so oftentimes for these patients, a lot of what we're dealing with tends to be not only the burden of bleeding, but also the burden of reconstruction. The last example I put up here is kind of the latest and greatest in what the Fontan has to offer us, as Tom will tell you, which is significant aortic pathology in these patients. So there are cases where we are referring these patients for transplant, given the significance and the really kind of gravity of their aortic disease. So this is a patient who came to us with a severely dilated neo-aorta, as you can see here, and we're seeing more and more of these patients who are being treated. The last subgroup of these patients that has something special to offer is the patients with aortic dissection. And so we're seeing an increased number of aortic dissections. Most recently, we treated a type B dissection in a Fontan, and my colleague Nimesh Desai over at University of Pennsylvania performed an intravascular procedure for that type B, and that patient is now coming back for replacement of his aortic root, ascending aorta, and arch. And this is in a 16-year-old young boy who essentially has a 6.5 centimeter aorta with moderate to severe aortic insufficiency, who suffered from a type B dissection when he awoke from surgery after having a humerus fixed for a skateboarding injury. So while you can see there are limited numbers of aortic dissection and congenital heart disease, we're going to start seeing more and more of these patients with hypoplastic left heart syndrome who present with this. In terms of our surgical treatment for patients with heart failure, you can see, hopefully this summarizes for you that these patients tend to have a very high early mortality and then tend to develop what is significant accelerated death or deterioration. And this is one of the more recent studies that I think is really helpful in terms of stratifying these patients, from Jonathan Menachem at Vanderbilt. He was one of our fellows here at Penn and has really done a great job of contributing to the adult heart failure literature in terms of looking at both patients with biventricular and univentricular heart failure and seeing kind of how you up the ante in terms of the pre-transplant complications, depending on the severity of heart disease. So while you look at patients who have biventricular or systemic right ventricles and how the Fontan patients differ, what's really a question is how these patients potentially with the Fontan will no longer be candidates for transplant, given the severity, of their heart disease. We try to look at mechanical circulatory support for these patients. Increasingly, this is a study out of Houston with Asami Hanjo as the lead senior author here, looking at patients who undergo ventricular assist support. We are tending now to, after the decade of 2011, this is Intermax data here, look more and more at patients who can have a hardware device as opposed to the other devices. And although we know that these patients tend to fare much more poorly than their non-ACHD colleagues, it is offering something towards these patients. In terms of assist device and the failing Fontan circulation, the cases are relatively low in number, but we're tending to build, of course, more and more patients who hopefully will be candidates for transplantation, and if not, destination therapy. My partner here at CHOP, Chris Mascio, started our hardware experience in the atrial position here, and this is often in patients who even had undergone a mechanical systemic AV valve, which was then removed at the time of transplant, and this involves putting a hardware in. This X-ray, you see it in a pediatric patient about 2 years of age, the lowest BSA being 0.59. And the other device that's available to us being the SynCardia. We've done 2 of them here at CHOP with kind of mixed results from those. The first who died from mediastinitis and the second who was successfully transplanted. When we look at risk factors for these patients, is certainly age greater than 50 and using a BIVAD or a TAH that are significant risk factors for these patients. By and far, these patients tend to be patients who have an LV for a VAD, as opposed to those patients who have single ventricle. When we look at the challenges of transplantation in these patients, really what's significant here, and this is kind of a conglomerate of multi-center studies from Jonathan Menachem's paper, again, looking at mortality. The early transplant mortality is higher in these patients, but tends to improve over time. So these patients survive the transplant itself. They tend to do better. The transplants tend to be technically difficult for these patients. We know that the 30-day mortality is significantly higher also in those patients with single ventricle disease. So survival of adults undergoing combined heart-liver tends to be no different from patients who have other forms of heart disease. And actually in our series, we learned that those patients don't tend to have as much heart failure as others. In terms of single center outcomes, most of this data is single center, but if you look at Dr. Menachem's outcomes here at the bottom, 100% survival at 30 days in 1 year in 20 consecutive adults with congenital heart disease undergoing both heart and heart-liver transplantation. The key here is how do we get most of our patients to survive? When we look at the data, this was a nationwide analysis up through 2014, looking at patients, 93 Fontan patients undergoing survival with an exceptionally high inpatient mortality, nearly 5 times that of non-Fontan patients, and a significant risk of both Ecmo and postoperative bleeding in these patients. In terms of heart-lung, something I'm not really going to touch on much here, but looking at heart-lung survival in our patients with congenital heart disease, severely lower than heart alone, indicating that patients who have increased pulmonary vascular resistance tend to be quite sick. And for those patients with congenital heart disease, they do, however, have similar outcomes to patients without congenital heart disease who undergo heart-lung transplant. So briefly, just to touch on our team here at HUP and CHOP, we tend to have a multidisciplinary team. We have the advantage of using kind of the best of the best from both hospitals. And here I mentioned some of our colleagues who are involved. We do get these patients through a pre-transplant evaluation. Their typical port of entry is through the Adult Congenital Heart Service, where they're evaluated, and then the ACHD center typically sends a checklist to our referring center so that we can get all the appropriate records here. They're all uploaded into Epic here, and then those patients are scheduled for a multidisciplinary conference once we have all their data available. Should we wish to proceed with conference, these patients are then kind of coordinated with a multidisciplinary conference and then undergo separate and individual consultation with each of the respective services. So on the medical side, both heart and liver, and on the surgical side, both heart and liver. And, the cardiac transplantation takes place if there are no barriers involved. Financial and cardiac insurability is also assessed at that time. We coordinate a 3-day visit to Philadelphia for these patients where they undergo extensive testing here, as well as those kind of transplants. And this is a process that really took some time to kind of refine. So by no means was this something that was developed overnight and has worked smooth every time. This, for each patient, we tend to kind of, as I mentioned, have this joint listing once the patient is listed. This is just some details about our surgical assessment here, which is kind of looking at, very simple. I start with kind of what are the basics in terms of the plumbing, the systemic and pulmonary venous return, what do we need to reconstruct during there, and what's going to offer us kind of increased risk during the transplant, whether it's the plane of re-entry for many of these patients who have had multiple reduced sternotomies, the accessibility for extra anatomic bypass for these patients, and determine what's needed for reconstruction for these patients, donor versus synthetic tissue. We only travel 2 hours door to door for our heart liver transplants, and ideally we only take patients who are less than 40 years old. We will take Hep C for these patients. We set up a testing schedule for each of these patients, trying to combine what the frequency of testing is and the schedule of testing for these patients, whether it be imaging or whether it be laboratory testing, and then try to coordinate their outpatient schedules as well. This is an example of one of our flight plans for these patients. As you can tell, it's very comprehensive in terms of what we do, and each patient has this kind of designated 7-page schedule available in Epic that every practitioner can access, and it's emailed at the time of transplant to everybody who is involved in that patient. So to go over our schedule at the time of operation, again, we have a preoperative discussion. Cardiac and liver anesthesia is present for that discussion, and they overlap with the patient. Both are present at the time of separation from cardiopulmonary bypass, as well as release of the cross clamp from the liver portion. The chest and upper abdomen are opened simultaneously once the donor organs are visualized. This gives us a chance to see the native liver. We stopped doing liver biopsy essentially because there was no point at which we decided we were going to do heart alone. And that was several years ago. We really feel that these patients are at significant risk. Again, for these patients, the heart transplant is done on cardiopulmonary bypass, at which time we come off bypass completely. We reverse our heparin completely. We assess our cardiac function. And there's been 2 cases now in which we placed our patient on Ecmo, gone to the ICU, rested the patient, and the patient has come back for a liver transplant once recovered. We leave our atrial cannula in place, and we can use those for VV bypass for the liver. Alternatively, as opposed to an atrial cannula, we can use an SVC cannula, which is flipped caudally. And then we complete the liver transplant with the chest open. We reperfuse with the cardiac team in the room, and afterwards the patients are closed simultaneously. These are some sketches done from an operative technique article we published looking at kind of how these patients are reconstructed, and it's pretty much standard technique for the heart transplant itself. And this is a schematic of the heart liver, here being a video which is just a little bit bouncy, showing both body cavities open. This is after implantation of the liver. The surgeons are kind of just examining there and inspecting for bleeding there. And as you can see the heart beating here with chest tubes being placed in the mediastinum, and that venous cannula is being removed from the SVC at that point. Both cavities are closed simultaneously. What we've learned is that organization is paramount for these. Administrative support is necessary. These are long and challenging, not only cases, but hospitalizations. We all bring a unique skill set, and it has to be shared. It's about education and buy-in across the board, especially the nurses are really paramount to the success of these patients. We've learned to expect the unexpected, and we often know that we have to share our limits with these patients and let them know that they can be delisted at any point. And it's all about kind of communication, and importantly, that if one team member waves the red flag and says no, no means no in these cases. So thank you so much for the opportunity to share with you. It's certainly a topic that I'm passionate about. And I think we're going to see more and more of these patients. Like I mentioned earlier, that the only way to really learn about this is meetings like this where we get an opportunity to share with each other. So Tom and Valeria, thank you so much. I really appreciate your kind invitation and being here.
Stephanie, thank you so much for a very comprehensive yet very clear presentation. You covered a lot of territory.
Yeah.
I'd say you dropped a lot of pearls and jewels from which we will all benefit. I think you made very many important points, and I think in this week of adult congenital heart disease awareness, I think it's important that we reinforce with the audience that congenital heart disease is not just a disease of children anymore. In fact, there are more adults with congenital heart disease than there are children with congenital heart disease. And it's interesting though, even though the numbers measure in the millions, for some of these complex lesions, a lot of the treatments that we have, the evidence base, is really in the 30, 40, 50 patient range, which really makes decision-making at this point in time challenging because we don't yet have the kinds of data that we need to make those decisions. Mm-hmm. That being said, I'd like to ask you you sort of kick it off. I mean, there's so many, we have a lot of questions that have come in from the folks that are watching remotely. But I want to kind of cut to the chase. So in patients with a failing Fontan, Stephanie, in Philadelphia, how do you decide who's going to get a Fontan conversion as opposed to a transplant? And if you're going to transplant them, if you can, again, review in a practical sense, who gets a heart only, who gets a heart liver? And then for the extra bonus round, have you done any heart, liver, kidneys? So
Yeah, great questions. So, realistically, I tend to think of these patients very much along a spectrum. So it's a little hard for me to separate, kind of the pediatric, teenage, adult patients from each other. But if we look at just the adult population, realistically, I think the majority of patients who were going to be converted, meaning taken down from an atrial pulmonary Fontan now to what is an extracardiac Fontan, Mays procedure, potential valvuloplasty, a lot of those patients are done already. We're not seeing the atrial pulmonary Fontans. So there's not really an opportunity for good surgical intervention at this point. These patients have already been kind of surgically optimized, so to speak. And then when you look at the patients who are failing adult Fontans, all our failing adult Fontans undergo heart liver. And we started taking that very kind of dogmatic pathway early on here at Penn. We felt that the risk of these patients, particularly their bleeding risk perioperatively, was significantly higher without the liver. And it's amazing how quickly you're able to dry out these patients once they have a functioning liver. The other thing we noticed about these patients was that they didn't tend to get rejection of the heart. We've had one patient with rejection of the liver that was treated, but otherwise these patients tend to do very, very well. And the liver is almost protective towards heart failure or heart rejection in these patients, which is very nice. And I think that has to do with kind of the sensitization. It's a hard patient population in the sense that they come with so many risks for transplantation. They're extraordinarily sensitized, knowing that they've had either homograph or they've had multiple bypass runs with potentially having, blood transfusions, platelet transfusions, and on top of that, the patients who then get a VAD who continue to be highly sensitized. So that tends to be a group that we're very kind of cautious about in terms of the transplant risk for them. Over here at CHOP, we tend to perform heart alone for these patients, but realistically, we've chosen that very aggressive pathway at the University of Pennsylvania, where all of our patients who are Fontans will get referred for heart liver.
Yeah, it's very interesting. We also have a pretty big experience with heart liver transplants, not just in congenital heart disease, but in acquired diseases. And it's kind of a big leap of faith to make in that two big operations, you think that the bleeding would be extraordinary if you put the two together, when in fact, it's just the opposite. Except, and I want to touch on this, these patients who have very extensive collaterals, APCs and veno-venous collaterals. And so how do you approach those? I mean, you mentioned the UCLA experience. They're very, very aggressive. How aggressive are you? I mean, do you try to get rid of all of the APCs before you go to transplant? How much is enough? Or is there ever enough pre-transplant?
Yeah, and to tag along with that question we have a question from the audience wondering how early in anticipation do we start coiling these collaterals, recognizing that the coiling also has some risks. So do we wait until the patients are listed or as they're being evaluated? So that's just a question on clinical timing for this approach.
Yeah, two great questions. And Tom, to kind of go back to your first question, the other thing that can contribute to bleeding in this population is, of course, their incidence of renal failure. So when we look at complications for these patients, we have a very high tracheostomy rate post-transplant, and we have nearly all our patients are placed on dialysis after this extensive surgery. And for the most part, it's been very temporary. So they do recover renal function. We have transplanted 2 patients who have been on, kind of touch and go dialysis prior to surgery. And those patients have required dialysis afterwards, but then eventually were able to recover renal function. But I do think that also contributes to bleeding in this population. It sounds counterintuitive that a bigger operation that has certainly a very long duration would minimize your bleeding, but it really does in this case. I think in terms of the patients who have the aortopulmonary collaterals, that's what we're trying to sort through. And we had an unfortunate patient demise with a patient who had severe collateral burden. So now we're trying to devise an entire kind of scheme of these patients in terms of where their collateral burden falls. And it's not just the amount of collaterals that they have, but it's the location of the collaterals. So just saying that patients who have a high collateral burden are no longer going to be transplant candidates isn't necessarily true. It's patients who have a high collateral burden within the surgical field. So around the pulmonary arteries, around the SVC, around the IVC. If this is kind of posterior mediastinum, if this is below the diaphragm, the liver surgeons don't mind the collaterals. They're used to these patients with portal hypertension. So they are amazingly unaffected by them, whereas we're very concerned when we see a lot of varicosities in these patients. I think the treatment, we have not actually pre-coiled or pre-treated any of our patients here. Our idea would be to do it at the time of transplantation. And that's what makes most sense for us, is once we have a suitable organ available, then that patient would potentially come to CHOP from University of Pennsylvania, get their collaterals coiled, and then go back to Penn for their transplant, as opposed to what they're doing in UCLA, which is serial kind of coiling and glue embolization of these collaterals so that you can kind of keep up with it. We know they grow back, so we like to kind of try to do this in time with the transplantation offer for these patients, if that makes sense. That obviously takes a tremendous amount of organization and flexibility and really teamwork to get these patients back and forth between two hospitals to do that.
Wow. That's
sounds easy, right?
Yeah, that's quite a dance.
Yes.
But that's very very interesting.
Yes, yes. We have another question from the audience. They would like to know what strategies or criteria do you use to upgrade these patients to higher status of listing, recognizing that they're substantially different from the usual indications for transplant, and that some of the criteria for non-congenital patients may not be as prominent in this patient population.
Yeah, Valeria, that's a great question. And I know that you all probably struggle much like we do in the sense that the revised UNOS listing for these patients in some ways puts our patients a little bit at a disadvantage in the sense that they're all listed as a status 4. We can apply by exemption or exception for them. But typically it's a hospital admission that really tends to help them. So whether it's the severity of their arrhythmias, whether it's systemic pump failure, and these patients benefit from becoming inpatient, and even putting them on a low dose of milrinone or a low dose of dopamine can be helpful. But we struggle with getting these patients organs. It's always the heart that pulls the liver, not the other way around. And of course, with the degree of sensitization, many of the Fontans tend to be smaller in size. It can be a little bit challenging. In that sense, I think we've moved towards listing our patients much sooner. So even if we have a patient, for example, one of the current patients who comes to mind who's listed really up until he moved to Philadelphia was working full-time. He moved here from Michigan for listing for heart liver, but was working full-time as a camera crew. So he's in film production, and he was lugging around a movie camera around a set all day long. So a highly functional guy, really felt awful when he would start to have these intractable arrhythmias. Has okay ventricular function, but not great. And recently we just admitted him again for decompensation with arrhythmias, which he underwent successful cardioversion. But I think maintaining him in the hospital now to say, gosh, you've been listed for 8 months, we haven't gotten a bite. Let's see what we can do. This is another sign to us that you're deteriorating. And listening to those subtle signs of not just saying, whereas maybe in another patient, you might be able to say, oh, we're going to bring him in for cardioversion, send him back out. Instead, we're much more kind of alert to the fact that this is a poor trajectory that he's on. And we know those patients kind of continue until they drop off a cliff. And trying to anticipate when that cliff's going to be and when they're going to drop off is the hard part. So anything we can do to bring them in-house, I think is very helpful.
So can you, Stephanie, please tell us about your experience with mechanical circulatory support? When do you and how often do you use temporary support? When do you pull the lever and go to more durable circulatory support?
Yeah, we have not been using temporary support mainly because of kind of the duration or the waiting time for these patients. Even if they were to get listed for us, it's still kind of very hard to find those ideal heart-liver combinations that are within, a 2-hour radius of Philadelphia. We tend to have long waiting times in general for these patients. It's interesting, I just reviewed an article looking at heart-liver off Ecmo, which I think is going to be kind of, a great idea for when you're potentially able to do that. And, looking at kind of creative solutions for these patients is really our next step here. I think in terms of durable support, we've used it in the pediatric population, but not as much in the adult population. And that's something that we're looking at exploring next. I think it raises the question, Tom, and probably you all go through the same process there in Texas, is saying, okay, well, how about not just using these devices as a bridge to transplant, but how about using some of these devices as destination therapy in our single ventricle patients? And realistically, with the shortage of organs, the long waiting time, should we be planning for kind of destination therapy on these patients? It's hard because they tend to do so well once they get a heart-liver transplant, as opposed to the potential morbidity from having a device in place. But I think realistically, given the organ shortage, we need to look at kind of, or potentially look at destination therapy for patients who are poor candidates for transplant.
I think you very nicely pointed out the point that, historically, I think our patients suffer from this misconception that patients with complex congenital heart disease shouldn't get heart transplants. Their risks are too high, the outcomes are really bad. And I think that with many of the advances that have been made in the techniques and the preparation for adult congenital heart patients, particularly the failing Fontans, the early outcomes are much better, and the long-term outcomes are really great. And I think in my mind anyway, the fascinating point, as you pointed out, is that patients who get heart-liver transplants, the rejection is remarkably less in the short and in the long term. So to that point, there are some centers that recommend doing the liver first in a heart-liver transplant, with at least the theoretical thought, the theoretical idea that the blocking effect of the liver will even make the risk of acute rejection less. What are your thoughts on that?
Yeah, we don't have any experience with that. I think certainly, we take advantage of the same unique donor for both organs. And as far as I know, the two ways that have been popularized is obviously the Stanford method, which tends to be simultaneous on block heart-liver. And then our method, which tends to be sequential, doing the heart first, making sure the patient's okay from the heart transplant, given the complexity of sternal reentry, bleeding risk, et cetera, and then performing the liver transplant with the same donor. So typically while we're sewing in the heart, they're doing the back table for the liver and kind of starting to get things ready in the abdomen to make sure we come off bypass or separate from bypass well. So I don't have any experience with the liver alone. I would imagine it would be fairly hard for some of these patients to tolerate, though, given the significant, I think probably the biggest thing for me is kind of the surgical risk inside the chest. So if you're going to perform a liver on veno-veno bypass, you would obviously, negate those. The fluid shifts, we've had patients crash coming off bypass after the liver just with the lactemia and the reperfusion. These patients don't take a joke very well. And considering that we have such little kind of to offer them in terms of what's temporary support, I'd be surprised to see a lot of that. I don't think that's something we'll be doing here.
So Stephanie, you touched on phrenic nerve injury, and many of our patients just over the course of one of the many battle scars that they have over the multiple operations that they've had is phrenic nerve injury and diaphragm paralysis. Do you address that at the time of the transplant? Do you placate the diaphragm? What's your approach to that?
Yeah, we haven't, but I'm not sure why we couldn't. I think probably it would be up to kind of the liver surgeons to do through the abdomen. They have great exposure through their chevron incision, and obviously with the liver out, that would give them even better time to do it. I think it would probably come down to timing for them, and especially if we're kind of pushing time, we do try to keep within 6 hours of ischemic time for both organs. So ideally, they'd rather kind of just move forward with it. I think for many of our patients, it's chronic debilitations. So a lot of these patients tend to be used to their lung function, and the new heart doesn't tend to be affected by it. So we don't see it quite as much. Oftentimes we just kind of mention it and suggest, hey, this is a patient who we're going to be really aggressive with rehab in, and this should potentially change what some of your expectations are for the pulmonary function afterwards.
I have one last question. For patients with a systemic right ventricle and congenital corrected transposition, when you're trying to decide between a systemic tricuspid valve repair or replacement versus transplant evaluation, does the age of the patient play a role in this decision? Recognizing that after a certain age, transplant may not be an option anymore for them?
Now, Valeria, typically it really comes down to what their ventricular function is like and their functional status. These patients don't tend to have as many systemic or multi-organ systems affected like the single ventricles do. I think that's frankly why they're better transplant candidates in a lot of ways. However, if their heart function is still relatively well preserved, we lean towards doing a valve replacement on those patients. And you know, again, it's fascinating. If you look at the studies, we're looking at 2 studies with around 40 to 60 patients in them, and that's kind of where we hang our hat. Even the resynchronization studies, if you combine all the patients, I think it's a total of 86 patients in those studies. So small number of patients. It would be great to kind of put together a national cohort of these patients and see what the results are once you look at kind of a larger number of patients. But in general, if we can do anything in a case where the pump works to kind of keep the patient's heart in and buy them time to a transplant, we'll do that.
Yeah, it's a interesting phenomenon with the corrected transpositions, and that I think many cardiologists and surgeons that deal with acquired heart disease would look at a patient with tricuspid regurgitation in the systemic ventricle and say, oh, you know, what's the big deal? You know, I do this kind of surgery all the time, but the cautionary tale is, you know, fools rush in where angels fear to tread. You know, the outcomes are, I mean, it's not the same as mitral regurgitation on the left side for degenerative mitral valve disease. This is kind of a chicken and an egg kind of question, Stephanie. I mean, the study from Columbia, I mean, is it the problem with the ventricle that causes the tricuspid regurgitation, or is it the tricuspid regurgitation that causes the problem with the ventricle, which makes these patients at higher risk?
Yeah, great question again. And realistically, we don't know. We do know that about 90% of these patients who have tricuspid valve regurgitation have a structurally abnormal tricuspid valve. So oftentimes these are the patients who were born perhaps with a VSD, and they have a degree of pulmonary stenosis that has kept their circulation in balance. Over time, typically during childhood, the tricuspid valve will almost serve to close that VSD. And those patients tend to the patients who are non-intervened on, that also renders the tricuspid valve kind of abnormal in some ways. And I think those are the patients who tend to develop the RV failure, are much more so the ones that have a structurally abnormal tricuspid valve. There is that relationship, and again, it tends to be this cyclical kind of downward spiral for these patients, where once they develop TR, they develop worse function, the function worsens, the TR worsens. And realistically, these are a very hard set of patients to manage. The other thing that makes them very challenging, I think, is the patients are kind of surprised that they need surgery. And oftentimes when they present for surgery, they're asking for anything but a mechanical valve, whereas these are patients who I almost exclusively offer a mechanical valve to, or limit to a mechanical valve, considering the complexity of the operation. Number one. Number two, many of these patients have dextrocardia as well, or have, bilateral SVCs, a large coronary sinus, things that can make this operation extra challenging. So getting in and kind of doing it once is the ideal for these patients, particularly since they tend to be younger and the tissue valves don't hold up in these patients, and we don't have any good evidence that these patients undergoing repair. I think the largest series looking at repair in these patients are coming out of Australia. And realistically, the repairs don't tend to hold up in these patients with the systemic tricuspid valve, very different again from the mitral valve that was built to be the subsystemic AV valve.
Wonderful. Dr. Fuller, I would like to thank you for this masterful presentation and for sharing your experience with us. You're a true pioneer in the field, and you have made such a big difference in so many lives of patients with adult congenital heart disease. We have learned a lot, and we hope to continue to collaborate in the care of our patients.
Well, thank you both so much. This was truly an honor, and again, I'm very grateful to learn from you as well, Valeria and Tom. Thanks so much for having me, and I look forward to your Adult Congenital Symposium on Saturday.
Wonderful, thank you. And I would like to take this opportunity to invite everybody to join us in all the events we have for the rest of the week for ACHD Awareness Week here at the Houston Methodist, and to join us for our symposium on Saturday. Dr. Fuller will kindly be joining us again there to continue to learn and how to help our patients better. Thank you, and until next time.
Until next time. Thanks, everybody. Thanks, Stephanie.
Thank you.